We can begin now.
Good evening, everyone. Welcome to Symposium 6 of MIOC. On behalf of MIOC and Ophthalmology Center, Armed Forces Hospital, Muscat, I would like to welcome our guest speaker today. He's Dr. Amr Farid. He will be talking on a deep dive in management of diabetic macular edema. Dr. Amr Farid has done his FRCS from Glasgow, and he's presently working as a consultant ophthalmologist at Maghrabi Eye Center, Dubai, UAE. Welcome, Dr. Amr. So over to you.
Thank you so much. I would like to thank you and thank Bayer for giving me the opportunity, and for the conference, of course, giving me the opportunity to present this symposium. I will just share my screen with you now. Okay, so let's speak today about the management of diabetic macular edema. So we'll try to make some questions and try to answer these questions and to help to reach some results, inshallah. And I will be happy to hear any questions at the end of the session, if you can, please. So what is the importance of visual gains? Does it really matter for the patients? So we see patients every day, and we see that the patient is losing vision or gaining vision, but what it really this means to the patient? It has to be if he, as first line, one line is lost, so there is a reduce of lost ability to drive or dependency on others and difficulty of reading the streets signs. And if two lines are lost, there is limited ability to work or perform the rule scientific function. Just a second. Three lines is lost, difficulty distinguishing between colors. So gaining vision is, on the other hand, if you gain one line of vision, you could help patients to read the newspapers and drive at night. Gaining two lines could improve near vision and tasks, or to focus on activities for longer period. Gaining three lines could help to improve the color perception for other patients. And gaining more than 20/40 could help your patients to take their license back, which is really, really important for a lot of our patients. So for the treatment of diabetic macular edema, we all know it's about doing anti-VEGF injections in the very beginning, but does it worth giving 5 monthly loading dose or no? So let us see this patient. This is a female patient, age 67 years old. This is one of my patients. She has cataract surgery, which was done 3 years ago. And she's diabetic 22 years ago, and she's uncontrolled. The HbA1c is 9.5. And she was complaining of blurred vision in both eyes. The visual acuity, or the best corrected visual acuity, was 0.4 in the right eye and 0.3 in the left eye. Anterior segment exam was fine, while the posterior segment exam shows non-proliferative diabetic retinopathy with clinically significant macular edema. So this is a typical case that we see every day for the patients of diabetes. So this is the OCT for the patient. This is the right eye, and this is the left eye, and you can see here in the left eye it's more than the right eye. You can see subretinal fluid, a lot of subretinal, a lot of edema, diabetic macular edema. So we started to treat this patient with Eylea injection, and this is the results after the first Eylea injection. You can see here is before, and now it is after. We can see the reduction in the edema in both eyes. Especially in the left eye, you can see also the subretinal fluid is gone, as you can see here. This is only after the first Eylea injection. So after the second one, it goes more and more to the anatomical, normal anatomical position. After the third Eylea injection, it's more improving. Also, the patient is improving in vision. At the end, after 5 Eylea injection, we can reach the optimum treatment. Still, there is some edema, but we have to continue, of course, after the label of giving every 2 months after this. But at the end of the day, the patient improved to 0.9 in both eyes. So this is what you see after having a good loading dose. This was correlated clearly with the VIVID and VISTA results. As in the VIVID and VISTA, there was rapid and increasing visual acuity gains were achieved with early and intensive aflibercept treatment. So you can see here in the first, after the first injection, you see good improvement. So the patients across both studies, the VIVID and VISTA, they improved more than 5 letters on average after the first injection. This is the same as we saw in the first patient or the patient. The second one, after 5 injections, patients improved more and more. So they keep improving after 5 injections, and then they maintain this improvement. So it is very important to continue drying the retina to reach the optimum improvement. So this graph shows us that 60% of the cases have improved from after the first injection. The 19% have improved from the 40 that is left, and like this until we reach the 5th injection. So we have many of the patients are improved. So 80% of the patients in 2Q8 group have gained more than 5 letters from the base line before the treatment, which is really gives us the importance again of giving the monthly injections in the 5 loading dose. So another question is the early shift is the clue. Do we shift early? We inject one time and then the patient doesn't improve, so we go for another anti-VEGF or go for another family of treatment. So for inadequate responders, what happened for these? The VIVID and VISTA, the eyes with limited early anatomical response, they continued to improve after week 12. So the patients who are not responded in the very beginning, as they are limited early responders, they started to improve after the 3rd injection, which we have again to restock again to our 5 injections. So if you saw improvement in the patients, significant improvement, or a little bit less, you have to still continue until you reach the optimum. So this is the difference between the limited early responders and the early responders. Here, the improvement at the end was about 8 to 0.6 letters, but here it was about more to 10.7 or 12.7 letters. This is also have been revealed by Protocol T. The Protocol T, the prevalence of the persisting diabetic macular edema, this continued to decrease with intensive treatment and was likely to persist with aflibercept. As we can see here, this is at week 12. So this is at week 12, we have 50% of the patients still have edema with aflibercept, 72 still have edema with bevacizumab or Avastin, 53 have edema with ranibizumab. So continuing the treatment, we reached to 24 weeks, the 31% having still edema with the aflibercept, which is the least in both in the 3 drugs, which is way more than the Avastin. Among the eyes with the persistent diabetic macular edema at week 24, those treated with having the lowest probability of chronic persistent diabetic macular edema at year 2. So again, so week 24, there were 32% of the aflibercept treated eyes. Bevacizumab, it was 60%, 66%, and ranibizumab was 42%. The 2-year treatment group comparison have showed that the probability of the chronic persistent diabetic macular edema was decreasing more with the aflibercept. So this continued to the end of the 2 years after the finishing of this study. Another question pops up, which is, does it allow the intensive treatment initiation, does it allow for reducing the burden after 1 year? So if you started very powerful like this, do we see this after? Do we gain this after the first year? So what we will see. Again, the VIVID and VISTA over 3 years, it was found that the number of the injections in the first year were about 8.5 injections. The number of injections here was about 5, and then it goes to 4.5. So it is decreasing. So that if you have intensive treatment in the very beginning of the treatment, especially in the first year, and you stuck with the label, which is 5 injections per in the first 5 monthly injections in the first 5 months, followed by every 2 months. This will help you and help the patient to decrease the burden of injections later on in the second and the third year. And this is the message that we have to deliver to our patients, to tell them that it is really very important to keep their vision and treat intensively in the first year. Another study, which is the drcr.net, the protocol I and protocol T, showed that intensive treatment in year 1 was associated with a reduction in injection burden in year 2 and beyond. Here we can see that this protocol I with the ranibizumab injections, it was started in the first year with 8 and 9, then it went to 2 and 3. This is, of course, with the prompt laser, ranibizumab alone and ranibizumab with the deferred laser. But in both groups, it was decreasing until it reaches 0 in year 5. And which is, it's really good to tell our patient that if you injected like this in the first year, you will gain at the end that you will finish up without doing any injections. The same was seen as well in protocol T, because prior to the second year, there were the changes in the first year and the second year. Here you can see 10 injections, which is decreased to 6 injections, and 9 injections decreased to 5 injections. So again, it's very important to deliver this message to our patients and to help them to maintain their vision. Do we switch between anti-VEGFs, or we have to switch to another group like steroids? So if you switch between the anti-VEGF, do they respond well or no? So in the VIVID and VISTA, or the VISTA itself, there was some patients they took injections before, either Avastin or they took before ranibizumab, and then they entered in the study. So we can see that this is the patients with having prior anti-VEGF, and this is the naive patients. So what happens to these patients? So this graph showed us, these two graphs showing us the laser treatment, either the laser prior treatment or the laser naive. But the other 4 graphs, these lines shows us the 2Q4, which is having prior treatment, or 2Q4 naive, and the 2Q8, the same prior treatment and naive. And we can see that nearly all of them has improved, and they reached a point which is nearly all the same. They gain the same vision. So at the end of the 2Q8, after 52 weeks, it was about 10.5 letters, and the treatment naive with about 11 letters. And after 100 weeks, or the second year, it was 10.8 to 11.3. So this was nearly the same. So the patient that had prior treatment before using Eylea, they could really gain vision, as well as the patient that they are naive. This is one of my cases, a male patient, which is age 56 years old, is diabetic 15 years ago. His uncontrolled HbA1c is 8.9. He had laser treatment before, and the complaint was decreased vision since 1 year. Examination, anterior segment was fine. Posterior segment, he has proliferative diabetic retinopathy. He had laser before PRP, pan-retinal photocoagulation, with diabetic macular edema in both eyes. So let us see the left eye. This is the worst eye. The visual acuity, best corrected visual acuity was 0.05, 2400, and you can see that these cysts are very big cysts, and it is difficult to be treated, and this tells us that this is a long-standing diabetic macular edema. So after 3 Lucentis successive injections, we tried to offer Lucentis for him in the beginning, and he took Lucentis injection. And the improvement, there is an improvement, but it is not that sufficient for me to continue on the Lucentis. As I told you before, we have to give the drug its own trial for treatment. I cannot give him 1 Lucentis only until know that he is not improved. No, we have to continue at least for 3 injections, in my opinion, to check if there is ability for this drug to treat the patient or no. So after the 3 successive injection, the patient was not really that much happy with the result, and me as well, because I was expecting to be more than this. But we switched to Eylea, and then after switching to Eylea, the patient improved after the first injection. This is the second injection. This is the third injection. And after 5 injections, he improved totally to 0.7. So you see that you can see this in some patients, either in Lucentis or either sometimes in Eylea, but you have to think that you have to give an optimum treatment for the patient before thinking to switch to another drug. The right eye was nearly the same. The vision was a little bit more. It's 0.1, but the edema, as you can see, it's all persistent edema with very big cysts and a long-standing edema. The same, he acts the same with this eye after 3 Lucentis successive injection. He improved again with the Lucentis, but this improvement was not sufficient for me. And then after Eylea, he started to improve once after injection, and the vision improved to 0.8 with after 5 Eylea injection. There is still some edema. We continued, of course, the after injections after 2 months. But I just want to show with you these cases that sometimes you need to switch after the initial dosing, that it is not giving you a good response. So what about the head-to-head comparisons between the 2 or 3 drugs? So what did the drcr.net say? So the protocol T with the head-to-head trial between the 3 drugs, and aflipercept was associated with greater visual acuity gains. In the first years, the improvement with aflipercept was 13.3 letters, and the ranibizumab was 11.2, while the Avastin was 9.7, which is the least one. After the second year, the Lucentis or the ranibizumab started to catch up, and it was nearly almost near each other. The aflipercept with about 12.8 letters, the ranibizumab with 12.3 letters, and the Avastin was 10 letters. But if you go for the area under the curve, you found on the whole study, patients which have a baseline of visual acuity which is worse than 20/40, they was way improved than the other patients. So the patients were treated with aflipercept were improved to plus 17.1, while patients treated with the ranibizumab was 13.6, and the Avastin was about 12. So this demonstrated that the efficacy of the Eylea or the aflipercept in patients of less than 20/40. Another study, or it is a survey which was done among doctors, when costs and payers are not an issue, what is the drug of choice that you will choose as a doctor? So this was done among the doctors, and it results in the aflipercept was having the higher percentage of 60% in the US and in the US, yes, and 70% in the ex-US, which is followed by the Avastin and the ranibizumab. So this is the choice of the doctors. If there is no issue about the insurance, no issue about the costs and the payers. So what we are doing in the clinical trials, does this is mirrored in our real world evidence or no? So the real world evidence have said to us that it's nearly the same. Let us go for this study. It's Lokich et al. This is a study which is done as a retrospective cohort at Moorfields Eye Hospital in London, UK. And they have checked the effectiveness of the aflipercept in the treatment naive patient with diabetic macular edema. So this is proportion of the patient gaining or losing vision. There was more than 10 letters, 47%, and more than 15 letters gained 34%, and the minimal amount have lost vision. And in this study, they studied also the patients which are less than 20/40 and the patients who are more than 20/40. So the patients less than 20/40, they have the most improvement. So they improved about 13.8 letters, while the others the more than 20/40 improved more than 2.6 liters. So this was really matching what we have seen in the Vivid and Vista in the numbers of the improvement and the regarding the visual acuity. Another study, which is called the Fight Retina Blindness, the patient with the baseline of less than 20/40 has significant greater visual acuity gain with aflibercept than ranibizumab. Here, the difference with ranibizumab, the patients improved 7.6, and here they improved 10.8 with the aflibercept. With the median of injection, the aflibercept was a little bit more of 8 than ranibizumab was 6 injections. So this again tells us how the effectiveness of the Eylea in the patients which are less than 20/40. The Apollo study, also another study which was done, and it gives us an gains with aflibercept in patients with diabetic macular edema were consistent with those reported in the Vivid and Vista. So this is the study. So the patients treatment naive or these previously treated, this will improve to plus 7.8, this improved to 5. The mean number of injection was about 7.6. The total improvement was 6.5. And this is the Vivid and the Apollo, the comparison between the Vivid and the Apollo. So here the improvement was 10.7 in the Vivid, the improvement was 7.8 liter in the Apollo, which is really nearly matching together. Number of injections here also was 8.7, and here it was 7.6. So it's nearly, the world evidence is nearly the same as the studies, the Vivid and Vista, which was made in the beginning. And this improvement here, it gives also the patient the driving vision. It's more than improvement, that's 70 letters that he can help him to gain his driving license and gain his good vision again. So again, what are the guidelines at the end is saying? The guidelines from Asia recommended anti-VEGF agent, of course, at the first line of choice of treatment. And in patient with worse than 6/12 or 20/40, aflibercept may result in more rapid visual acuity improvement than the ranibizumab over 1 year. Although this difference was not statistically significant in year 2 for the DRCR.net protocol T. Also, the retina guidelines recommended the same thing. This is anti-VEGF agent at the first line of a choice, and it is the aflibercept is the drug of a choice in diabetic macular edema with less than 20/40, as it shows superiority to the bevacizumab over 2 years and over ranibizumab in the first year of treatment. So both the Asian guidelines and the Retina guidelines emphasize the same thing with the protocol T, that the patients that are less than 20/40, that you have, it's better to have to start with the Eylea treatment. In summary, diabetic eye disease is a growing problem worldwide, and the clinician is endeavored to improve the patient lives. Early intensive treatment in year 1, again, it's very important because it ends with rapid and increasing vision gains through initial monthly dosing that are maintained at the long term. So again, this is a very important point, and if you got this point only from the whole lecture, it will be fine, because this is the goal or the key to treatment. If you treat early and intensively, you will keep the vision, and the patient will gain good vision, and it will help him to decrease the burden after this. On the other hand, delaying treatment may lead to irreversible loss of vision in diabetic macular edema. So if the patient is not treated and he delayed his treatment or having interrupted treatment, this will lead to irreversible loss of the function of the retina or irreversible loss of the cells of the retina, and you cannot treat him anymore. Vision gains achieved with intensive treatment, they can be maintained with a pronounced reduction in the injection burden in year 2 and beyond. Anti-VEGF therapy is recommended as first line of treatment in diabetic macular edema, of course, while aflibercept, as the guidelines showed us, is the preferred choice in the eyes with baseline visual acuity less than 20/40. Baseline vision is what the guides the anti-VEGF choice of the diabetic macular edema treatment. And emerging data from clinical trials underline the efficacy of the aflibercept treat and extend treatment in year 1 and beyond. Thank you so much, and I'm ready for any questions.
Yeah, I'm just checking if any questions are there.
Yeah, no problem.
That was an excellent elaborative talk, Dr. Amr, based on clinical evidences.
Yes, of course. Thank you.
And you have answered most of the dilemmas which we come across in a clinical practice. I would like to convey regards from Dr. Rashid. He just messaged me.
Yeah, okay. I would like to see him in an old.
Yeah,
I would like to see him. Say hi to him, please.
Yes, thanks for sparing time from your busy schedule.
Thank you. Here you are.
And I hope to see you again in future. Yeah, there are no questions as such as of now.
So I think we are done with the session then, Doctor.
Okay, Doctor.
Thank you so much.
Thank you once
Thank you so much.
again.